Good afternoon, everyone. I'm Sir Franz, and this will be our last lesson for drug development for prelims, and we're going to talk about SARS-CoV-2, severe acute respiratory syndrome caused by coronavirus 2, also known as COVID-19. So we are presented first with the case. A 20-year-old male, young adult male, presents to the outpatient pharmacy with a 3-day history of runny nose and nasal obstruction and conjunctival injection. So 3 days ago, he had watery runny nose. There is a feeling of nasal stuffiness, nasal obstruction, and he has conjunctival injection, which means the conjunctiva, which is the mucosa covering the sclera of the eye, is quite edematous and red. 2 days later, he developed lethargy, which is weakness, muscle and joint pain. So this is your myalgia and arthralgia, dry cough, and fever. Dry cough means the cough does not produce any sputum, and fever. So that is 1 day ago. He took Decogen, which afforded slight relief. And remember that Decogen is a combination of phenylephrine, a vasoconstrictor, paracetamol, which is an antipyretic, and a little bit of an analgesic, and chlorpheniramine, which is an antihistamine. There was no noted decrease in urine output, difficulty of breathing, chest pain, decreased consciousness, or altered mental state. No diarrhea and no abdominal pain. So the rest of the organ systems seem okay. Because you were thinking that this patient probably has COVID-19, knowing that the prevalence of COVID-19 in the community is quite high, you advise the patient to seek consult. And when the patient went to the doctor, the physical examination revealed the following. The blood pressure is 110/80 millimeters of mercury, so that's quite normal. There is no hypotension. The heart rate is 105 beats per minute, so the heart rate is elevated. You have slight tachycardia. The respiratory rate is 23 cycles per minute, so you have tachypnea or fast breathing. And the temperature is 38.5 degrees Celsius, so the patient is febrile. It was also observed that there is an erythematous, meaning red, nasal, and pharyngeal mucosa. So the throat is also red. The patient has cervical lymphadenopathy with cervical lymphadenopathy, which means that the lymph nodes of the neck are enlarged. There are fine crackles at bilateral lung fields, which means when the doctor listened to the lungs, at the inferior portion of the lungs, he can hear fine crackles, high-pitched crackles, which means that there is a little bit of fluid accumulating within the alveoli of the lungs. And the rest of the exam was unremarkable. So the doctor ordered reverse transcriptase polymerase chain reaction, RT-PCR, of the nasopharyngeal mucosal swab, and it turned out positive for COVID-19. We are then to ask this question: what are the clinical manifestations of COVID-19? So this slide is very important because this is how we'll be able to determine a probable case of COVID-19 short of an RT-PCR. So this is from the Calgary Guide, which is a very nice website to learn about diseases. This slide emphasizes that the symptoms are on a continuum, which means that any of these findings may be present in a patient with COVID-19, depending on the severity of the disease. So for mild, you have fever, cough, myalgia or muscle pain, fatigue, nausea or vomiting, diarrhea, and loss of taste or smell. So, if you will observe, there are a lot of organ systems affected, and therefore you can think that COVID-19 is a systemic viral illness. If the COVID-19 infection is moderate up to severe, there will be specific or particular affectation of the lungs, which will manifest as worsening dyspnea. Dyspnea means difficulty of breathing. That will manifest as an increase in respiratory rate and a decrease in oxygen saturation. So the lungs are having a difficult time performing their function of eliminating carbon dioxide and oxygenating the blood. If you order a chest x-ray, you will see that there will be bilateral, which means both sides, bilateral interstitial infiltrates, which means that there is fluid or exudate accumulating in the alveoli. And these are progressively worsening as you go along. A patient may even present in the critical state, which is what we want to avoid by giving the patient COVID vaccine. So in the critical state, it is understood that this patient is decompensating and has a higher risk of mortality or dying. Critical state, you have respiratory failure, septic shock, and multi-organ dysfunction. So respiratory failure, that is a severe form of inability of the lungs to perform its function. Oxygenation, so the blood will have very low oxygen, and removal of carbon dioxide, so the blood will have lots of carbon dioxide. Septic shock is a systemic state. The cells of the body are not able to receive oxygen. That is because of failure of the cardiovascular system. And this failure of the cardiovascular system is because of widespread inflammation. And lastly, if the inflammation is very severe and the circulatory support to the different organs have gone down, then the different organs of the body, the kidneys, the liver, the brain, the lungs, the gastrointestinal tract, and even the endocrine system will undergo dysfunction. So that's your multiple organ dysfunction, or MODS, multi-organ dysfunction syndrome. So based on those clinical manifestations, we now ask the question, how does COVID-19 develop? So this is a slide from physiology.org. It tells us that first, there should be viral infection. This is the virus, COVID-19, and it enters the system, the human body, by way of the respiratory tract. So there is viral infection via the ACE2 and TMPRSS2, TMPRSS2, and these are receptors that you will find in the alveolar cell. So your epithelium of the lungs, they will express these proteins, ACE2 and TMPRSS2, and this is where your virus will attach and be able to penetrate the epithelial cells of the lungs. So you might be familiar with ACE2. ACE2 is your angiotensin converting enzyme 2, which converts angiotensin 1 into angiotensin 2. So that enzyme, which is inhibited by your ACE inhibitors, is the same protein that is used by SARS-CoV-2 to attach to the pneumoepithelium. Then there will be active replication and viral release, and this causes pyroptosis, where the pneumoepithelium will die of apoptosis, but at the same time stimulate an inflammatory response. So at this stage, number one, viral entry and early infection, the virus propagates and replicates. But the damage to the human body, which results to the manifestations, have not yet kicked in. It is actually the host immune response trying to eliminate the virus, but at the same time damaging in collateral the human cells that leads to the manifestations. So you have damage-associated molecular patterns and pathogen-associated molecular patterns. These are recognized by the immune cells of the body. The immune cells, in response, they have identified the virus and they have identified the host cells which have been infected by the virus, will now release cytokines and chemokines. Cytokines are ways by which the different white blood cells of the body talk to each other. Chemokines, on the other hand, are specific cytokines which will tell the white blood cells that this area has been damaged. So they recruit white blood cells. Those are chemokines. Monocytes, macrophages, and T cells are then recruited, and eventually this will lead to elimination of the infected cells and the virus. But if the immune system is dysregulated, it is not able to perform its function, you will now transition from a mild to moderate or severe COVID-19. And the once original host immune response will now convert into a hyper-inflammatory immune response, which has elevated activity of the immune system to the point that it damages the different organ systems. So there is excessive infiltration of white blood cells into the lungs, and this is due to your cytokine storm. Elevated interleukin-6, these are cytokines, interleukin-6, interleukin-10, 2, IP-10, granulocyte colony stimulating factor, interferon gamma, tumor necrosis factor, and M1P1A. So all of these are the effectors of the immune system. This is how the immune system functions in a normal state. But if you have a hyperinflammatory state, then you have elevated levels of these cytokines that eventually leads to organ failure. So the systemic overproduction of these pro-inflammatory cytokines damages the normal cells of the body, even those that have not been infected by COVID-19. And there is aberrant regulation of the immune response. So with these cytokines being spewed into the systemic circulation, going into the different organs of the body as blood circulates throughout the body, it also affects the different organ systems, the brain, the hematopoietic system, including the blood and the bone marrow, the kidneys, the liver, and the heart. You have extra pulmonary outside the lungs, extra pulmonary organ involvement. And there is activation of a procoagulant response, which incites coagulation that is not needed really by the body. And that coagulation will lead to cutting off of the blood flow to particular microcirculatory beds in the body. This further aggravates the organ failure. So with that in mind, we then ask, how do we treat COVID-19? We can have monoclonal antibodies or neutralizing antibodies that bind and coat directly the virus. This neutralizes the virus and prevents its entry into the cells of the body. Okay, let me go through some of the more important agents that we use right now for the treatment of COVID-19. There were times, months ago, when they still used chloroquine and hydroxychloroquine, but recent randomized clinical trials have debunked the use of chloroquine and hydroxychloroquine, so we don't use this anymore. What we use, especially in mild to moderate COVID-19, will be the viral RNA inhibitors, which are remdesivir and lopinavir. So these drugs, remdesivir and lopinavir, will inhibit RNA polymerase. So if your RNA polymerase is inhibited, you will not be able to synthesize viral RNA, and without viral RNA, it will not be able to produce viral proteins. And without the viral proteins, there will not be assembly of the mature virus particle. So you can't make virus particles because you inhibited RNA production. Next, you have to recall that central to the pathogenesis of COVID-19 is a dysregulated host immune response. There are just so much cytokines and so much white blood cells that damages the normal cells of the body. And so we also have drugs to ameliorate the hyperinflammatory state. For example, we have tocilizumab, which is currently being used rampantly in the hospitals to treat moderate, even up to critical COVID-19. Tocilizumab will bind interleukin-6 and prevent the activity of interleukin-6, and therefore it dampens the inflammation. What we also use right now, especially in patients who have been ventilated, they are hooked to a ventilator, a machine to help them breathe. If they are already hooked to a machine, then what we found is that glucocorticoids, for example, prednisolone or methylprednisolone given via IV, actually improves the immune response, again, because it is a glucocorticoid, which is an immunosuppressant. It improves the host response to COVID-19 and improves the mortality. So these patients will die less often if we give them glucocorticoids. Patients who have been in severe and critical who require mechanical ventilation. Remember a while ago that the host immune response, especially in critical phase where there is multiple organ dysfunction, will lead to a procoagulant state. And that's why by giving patients low molecular weight heparin and even unfractionated heparin, we can prevent the development of blood clots and improve delivery of blood to the microcirculatory beds of the body. So these are the more important treatment options that we have. But at the end of the day, our goal is really to prevent the patient from going into the severe and critical phase. What we want is the population staying in the mild and even in the asymptomatic and even the non-infected state. So we don't want them to go into severe and critical because that will cost the patient and the government, hospitals and their resources a lot. We want them to be not infected in the first place or to just stay in mild, where the treatment is just supportive. So we use vaccines to do that. And what is our dictum with vaccines? The one that is available in your locality is the best vaccine. So we asked the question, what are some vaccine technologies that we use for developing the SARS-CoV-2 vaccine. Number one would be a modified adenovirus, and this is your Oxford and AstraZeneca vaccines. So what we do is we get nucleic acid from the COVID virus. So we just get the nucleic acid, which codes for the spike proteins. The spike proteins are the proteins on the surface of the virus that attaches to ACE2. So what we do is we get the DNA that encodes for the spike protein. We insert that DNA into a relatively non-pathogenic virus like adenovirus. So we insert the nucleic acid into adenovirus and we inject the adenovirus into the patient. And as the adenovirus, which is non-pathogenic, infects the host cells will now start making their own spike proteins. And once the host cells make their own spike proteins, this will be detected by the immune system, and the immune system, by way of your B lymphocytes, will now start making antibodies against COVID-19. The next one would be your encapsulated messenger RNA encoding the spike protein. Again, the messenger RNA, by way of the central dogma, will make the spike protein. But this time, what we do is we just get the messenger RNA that encodes the spike protein and infuse it into a lipid nanoparticle, which is some form of microsomal technology. So you envelop the messenger RNA with the lipid, and this lipid, like lipoproteins, will circulate in the blood, into the systemic circulation, and penetrate the cells of the body, where the cells of the body will use the messenger RNA to make spike proteins and again stimulate the immune system to make antibodies. So we have here the Sinovac vaccine or CoronaVac, which is an inactivated virus vaccine. So what we have here is a vaccine made up of the dead virus. And that dead virus, because it's already inactivated or dead, will not be able to cause disease. So even in immunosuppressed individuals, it will not cause disease because the virus has been inactivated already. But even if it is inactivated, it will still stimulate an immune response. Next, we have these ones, which are still in development in the laboratory. We have your lentiviral vector, modification of dendritic cells. So here is your antigen presenting cell, which is a dendritic cell. We get that, and then we get a lentivirus vector, which is a virus, again non-pathogenic, carrying the spike protein. And we infect the dendritic cell with that virus vector, and you have here your LVDC, so lentivirus infected dendritic cell, and we get these here, incorporate it into the vaccine, and we inject this one subcutaneously. And remember that your dendritic cells interact with the lymphocytes, and they activate the lymphocytes to elicit an immune response. So here, you help the body activate the lymphocytes by giving primed dendritic cells. The next one would be artificial antigen presenting cells, so quite the same technology. But here you use SARS-CoV-2 antigens already. So the same technology, same concept, activating the immune response. Okay.